So probably it's a little bit awkward because it's not truly about statistics, but I want to stress on anatomy first. And I have to confess, I'm not the true type of researcher. So this probably mostly from my experience. So today I'm more talk about CLE and just a normal endoscope. And I'm gonna show a little bit about the Barrett's esophagus from west and east. So this is most complicated slides. I have a lot of anatomical terminologies. You don't need to remember all, but I hope some of you may understand CLE and PCA. So CLE and PCA, we need to start from PCA. PCA is a pinch-cock action. The pinch-cock action is something holding esophagus and stomach. So this one is the diaphragm holding that area. So Gerwang holding that areas. If the PCA is unwell, the stomach mucosa is going up, like Dr. Dirk already mentioned about GERD, downward, and in this case, the columnar epithelium is going up to esophagus. It made columnar lined esophagus. This is main topic for today. This is also a very important slide or anatomy. Whenever our endoscopist perform endoscopy, if we find any abnormalities around the EG junction or G junction, we need to write down. Hello, can't you hear? Whoops.
Yes, we hear you.
Okay, thank you. So whenever we perform endoscopy, we need to write down if the pathology either on the right wall or on the left wall or posterior wall or the anterior wall. Thank you so much, Professor Dirk. Professor Dirk mentioned that one of the treatment options for GERD patients, we do our best, ask patients, lie on your left, not right. This is the reason why most reflux done in right-sided, the short segment Barrett esophagus most commonly happens in the right side wall. So that kind of recording is very important in order to follow our GERD or Barrett's esophagus patients. So in fact, where is EG junction? So this purple color is the stomach. So stomach is quite anterior side, but to my surprise, when I studied this, EG junction is quite posterior. So for example, if we rotate stomach either counterclockwise or clockwise, depends where you are looking at. So most part of upper stomach is higher than EG junction, in particular right side. So we believe probably 10 years, 20 years, 30 years continuous reflux may make Barrett esophagus. So Barrett esophagus or even esophageal adenocarcinoma, probably from GERD. And thankfully or luckily, all the Asian countries, East Asian countries, we have very low incidence of Barrett esophagus, except Japan. Why Japan is quite high in terms of incidence? Probably because they made their own definition. The Japanese Association or Society made Barrett's mucosa. This isn't the definition of Barrett's esophagus. On the other hand, West doctors, American Association made no Barret mucosa, they have only Barret esophagus. This is more easily understood because all the lesions is about 1 centimeter proximal or from the EG junction or G junction, and pathology must show up intestinal metaplasia. So disanjut, and the color is a salmon color. The 3 components together make the definition of Barret esophagus. This is the Western style definition. Okay, back to Japanese style, because we still need to learn something from Japanese society. So if we carefully look at the EG junction, there are 4 types. So type B is the hiatal hernia, and then columnar lined epithelium. This is 2 types of Barret esophagus, but Japanese adopt that area, not yet Barret esophagus, but they call this Barret mucosa. So like this, whenever the palisading vessels going down there, and still apparent is able to see that kind of palisading vessels, the Japanese doctors diagnosed Barret mucosa. I'm sure that's why Japanese population, 2%, up to 2% are in the category Barret esophagus, but not other Asian countries. But this is not only Japanese style. Let me check out other countries too. So before this, I'm gonna introduce the American style again, or Western style, or traditional style again. Think about there are only 2 components, esophagus and stomach. It's very delineated because pinch cock is holding that areas very well. Whenever pinch cock is out of areas, the gastric mucosa is going up the esophagus and then made a CLE, columnar line esophagus. This is basic concept of Barret esophagus. However, can we just simply diagnose this as CLE, or is there any CLE-like? In order to distinguish CLE from CLE-like, biopsy must be proven as the intestinal metaplasia. So again, the 2 component palisading vessels is from the esophagus, but gastric folds is up from the stomach. The 2 component is quite important. These are very interesting and important parameters or landmarks. So let me have the delineation again. Whenever we see the gastric fold is up, this is up, but whenever we from the esophagus is down, this is down. So between those, this is Barret esophagus or CLE. However, they both have problems. If we adopt gastric fold as parameter or landmark, we cannot see or very hardly seen gastric fold just in case the patient with hiatal hernia or cardiac atrophy. So in both cases, gastric fold is likely disappear. It's very difficult to see the gastric fold. On the other hand, if we follow Japanese doctors as we adopt palisading vessels sometimes or many times it's very hard to visible. In particular, nowadays, we have a lot of goime. If the air is not good enough, oh my goodness, it's almost impossible to check out the palisading vessels. So still there's a problem, CLE-like or CLE. I know that every day in any Trung Noi soil in Vietnam, we can see hiatal hernia, many cases. So this is not CLE, looks CLE-like, but there's no columnar lined epithelium because hiatal hernia got those areas. This case, hiatal hernia, and then columnar lined epithelium. This is kind of true type Barret esophagus. But unfortunately, or interestingly, among East Asians, we have a few cases or increasing cases of only CLE without hiatal hernia. Is it true type Barret esophagus? Let me unfold it. So back to the palisading vessel. Whenever we perform endoscopy, we see the palisading vessel, we may see, okay, this is Barret esophagus. No, if we put her, it's going up. So this isn't palisading vessel, the overdiagnosed. What about this? This is, we cannot see palisading vessels. However, if we more inflate, if we bump her, we can see palisading vessel here. So this is Barret or CLE. This is a little easy because the hiatal hernia plus palisading vessels. So for far view is a hiatal hernia, near view is a palisading zone. So this may be Barret esophagus. Again, in order to diagnose Barret esophagus, so most countries requires metaplastic columnar epithelium or specialized columnar epithelium. This is only possible through biopsy in case of the endoscopically 1 centimeter above the ED junction. Why this is important? Because this is the real evidence that intestinal type or stomach type or specialized epithelium already invaded the esophagus. So pathologists using Alcian blue, but we gastroenterologists can use methylene blue. And traditionally in the European countries, maybe our professor he can give me some comment on this, but methylene blue in traditionally is quite important techniques in European countries. But before methylene blue, usually use acetic acid. So after using acetic acid, methylene blue chroma endoscopy, after using a cap attached. However, still a lot of countries, we haven't been unified or unificated in terms of definition of Barret esophagus. So for example, Americans are strictly asking intestinal metaplasia, and most European countries also following that areas. However, columnar-lined epithelium, this doesn't require intestinal metaplasia. Japan is following 100%, but many parts in UK and Canada also following that areas. So simply say, UK and Japan say columnar-lined epithelium is almost, or in Japan, is the 100% equivalent to Barret esophagus. However, America and most part of European countries say, no, we must need a proof, which is intestinal metaplasia or specialized intestinal metaplasia in order to get proper diagnosis of Barret esophagus. So in order to get that kind of intestinal metaplasia, biopsy is required. America, they have Seattle protocol because after Seattle protocol, intestinal metaplasia is going up to Barret esophagus quite often. So that's why the endoscopist and pathologist work together for diagnosis. But for us, endoscopists, our number one responsibility is that whether or not it's a short segment or long segment, because the most European countries in America, this long segment is quite related to esophageal adenocarcinoma. But Asians, it's quite interesting statistics coming up. However, short segment also related to cancer. So the length is important. And thankfully, I do thank to the PRA or PREG criteria. PRA or PREG criteria is about the length, whether this is a long segment or short segment. So far, I only trust PRA criteria. So I hope all our doctors in Vietnam also practice PRA criteria in order to get the length of Barret esophagus. So this is our responsibility. For me, anytime I diagnose Barret esophagus, I sit down on the table and then follow all this for about 5 minutes because this is important. Of course, I use imaging modalities, but today I'm not gonna say because of time issue. But that's all about histopathology, and CAP is quite needed. So back to the serial biopsy protocol. That is the most Western countries, including Australia and New Zealand, follow serial biopsy protocol. In Korea, we don't follow serial biopsy protocols because we don't say that it's beneficial. I don't know much about the stanza of our Vietnamese colleagues, but this is for short segment at least 8 biopsies, long segment at least 12 biopsies. It's quite huge protocol. But biopsy on the distal esophagus is not easy because this all was the tangential direction. Tangential direction means whenever we push out the biopsy tips, there's always a slipping. So joke is a very serious issue. That's why American College of Gastroenterology, they require turn and suction. I love the techniques. Every day I follow turn and suction techniques. So turn and suction techniques, whenever I push out the synthetic, I always make 90 degree, which is a perpendicular degree. So 2 cups must locate in perpendicular degree. Other than that, it's always a slip down to the cardia, which is horrible. So whenever I find that something abnormal mucosa on the distal esophagus, I use short knob, small knob, or long knob, or even talking the scope. And whenever I must make the perpendicular, and then suction, and then biopsy. So like this. Yeah, MBI, methylene blue, again, is helpful, but there are a lot of poor inter-observer agreements. This is the responsibilities of pathologists. After we do a lot of biopsies, the pathologist must follow us and finish all kinds of things. Why Barret esophagus is a main issue for Westerners or Caucasians? Their fear is something similar as our fear on stomach cancer. Because when we diagnose atrophic gastritis, we always concern about gastric cancer. For Western doctors, whenever they found Barret esophagus, they fear about esophageal adenocarcinoma. Because the Barret esophagus and intestinal metaplasia is quite related to cancer. So like this, maybe from Barrett's mucosa at the low grade, but since high grade, this is cancer, so we need to go further treatment. Yeah, there are some risk factors, and some Barretts may go to early esophageal adenocarcinoma like this. Yes, East and West is quite different. Okay, this is Korean cases about Barrett's adenocarcinoma. Interestingly, it's not long segment. It's mostly about 80% is short segment. So we are struggling with the length, location, and color issues. Location issue, as I mentioned, and then Jause Dirk already mentioned, this is the right wall of the distal esophagus. So if the right wall has something problems, that's more cancer-like or Barret esophagus likely. So we need to record like this. This is more Barret adenocarcinoma happens most case in Japan, happens in right wall. Color-wise, maybe reddish in normal endoscopy, and then MBI is brown color. Yeah, I'm not sure much about it, but I practice, and for me, it's the same result. So I'm gonna conclude my sharing. The road to detect Barret dysplasia or pre-malignancy is very hard, but I do emphasize the time because the longer inspection is #1 prerequisite in order to diagnose Barret esophagus. In Korea, we require 1 centimeter Barret mucosa requires 1 minute of examinations. In America, they say Barret inspection time, or PIT, requires 7 minutes. So like when we do colonoscopy, in order to find the colon adenoma well, we spend at least 6 to 7 minutes when we return. So it's something similar. The Barret esophagus, we need the 7 minutes or at least 1 minute or 2 minutes to inspect that areas. And then we have to learn those kinds of stuff as well. Surveillance is usually after the biopsy. If the biopsy shows non-dysplasia, don't worry. In most of you, the guidelines say at least 3 years. We have our own guidelines because all Koreans over 40 years old, they must do, or they are required to do upper endoscopy every 2 years, once other years. So if non-dysplasia, we don't have specific guidelines. There is one interesting category for Barret esophagus. This is indeterminate for dysplasia. This is not Barret, but looks Barret like this. It's quite common. I'm sure many of our colleagues already experienced those things. Biopsy usually don't say it's Barret because this is indeterminate for dysplasia. In this case, PPI 3 months, and it's gone. So this is not Barret. Conclusion, practice made easier. So whenever we are going to finish our gastroscope, we may see that kind of hiatal hernia. If you see that kind of hiatal hernia, please imagine like this. For me, I never look at my endoscope. I always ask my nurse, what centimeter am I? And my nurse say, oh, now you are 40 centimeter. Thank you. What centimeter now? Because I checked that there's only height hernia. My nurse say, oh, this is 37 centimeter. And I just found the circumferential Barret areas. What's the centimeter? It's a 34, and the top 33, and then I write down like this. Yes, I learned this for practicing for many years. So it's not easy to get that kind of skill in one day. America has many programs about this. Again, probably you may forget everything, but please remember these slides. Whenever you do like this, you control air and try your best to find the palisading vessel. Other than that, please find gastric fold. And then think about those kind of lesions, especially right wall, is more cancerous areas. We may need more statistics and then some consensus with our pathologist. Thank you.
Thank you very much, Dr. Chung.